Hello, everybody. Welcome to today's webinar. My name is Dr. May Lin, and I'm the Assistant Dean of Graduate Medical Education, Technology, and Program Development at Touro University, California. Today, we're going to be talking about integrating AI into graduate medical education. We're so pleased to have you join us on this webinar and hope that you can bring a few pearls back to the clinics and the places of education. And we're really thrilled to be speaking on this today. A little bit about me is that I have a background in technology and healthcare. I do clinical care through Amazon One Medical and have been a family medicine physician there since the early startup days. And so this is a topic that is near and dear to my heart. At One Medical, I had the privilege of participating in leading some of the efforts for clinical leadership development and really found myself loving teaching, and so entered into graduate medical education a couple years ago at Touro University. At that time, AI was just starting to take off, and we all kind of grew into this space where we were kind of all wondering what is happening with AI and how is it going to impact healthcare, leading into some thoughts about how AI is also influencing how our learners learn and how we teach. So this is true not only in undergraduate medical education and graduate medical education, but also for clinicians in practice. And so I've been very honored to be serving on many national committees around this topic of AI and medical education, including leading some of the efforts at AACOM, participating in some of AAMC's national efforts, as well as the Society of Teachers of Family Medicine, AI and Medical Education Task Force, some work with the National Academy of Medicine and the Global Health Professions organization there. Also the American Osteopathic Information Association. So I've had the privilege of learning so much, and I hope I could just share a few of those things with you today during this webinar. Thank you again for taking the time to join us. Without further ado, we will get started. In this talk, I am showing a little bit of an unusual picture of AAA maps. And I want to use this as an analogy for how we approach and think about how technology has influenced our day-to-day living, not only as just regular people and consumers, maybe parents, maybe students, maybe teachers, but just as human beings living day to day, how has technology changed the way that we approach how do we get from destination A to destination B? So back when there were AAA maps, no Google Maps, no MapQuest, we used to take out paper maps, unfold them, and on family road trips, my dad would notoriously pull out the big highlighter to really trace the route for our family vacations over the summer. Well, over time, the technology became available for us to be able to search our destinations from point A to B through MapQuest. And so we would then start printing out our instructions for family road trips. And then came what's called the GPS that we were able to mount onto our cars. That really changed the way we approached family vacation. No longer did we have to take out that big AAA map with the highlighter or the MapQuest, but we could just punch it in and boom, we would have a roadmap for how to get from destination A to destination B. Well, then we started having our smartphones and apps that supported this ability to navigate our destinations just through the touch of our fingers. And today we find ourselves in a little bit of a paradigm shift of having driverless cars, where I don't know how many of us have been in or seen a Waymo, but on the streets of San Francisco, where I live, it was a little bit disconcerting in the beginning to see a car drive itself with passengers in the back seat and no driver at the wheel. But over time, it kind of became something that felt a little bit more normal. Well, we want to use this analogy to think about how technology has changed the way that we approach teaching our learners in graduate medical education, how we approach healthcare with our patients as well. And sometimes it feels a little bit like this picture where we're kind of driving on icy roads, and it feels a little bit disorienting when the car is not going in the direction that you're hoping that it's going to go. It's windy. It seems to change really fast. And how can we prepare ourselves to feel like, wow, a potential risk is entering into our lives as consumers, patients, physicians, learners, teachers, professors, and how do we mitigate some of that to be able to drive in the safest way possible? It really takes like a series of thinking about how we approach this new technology. What type of guardrails do we want to have in place? How do we understand how it works? Maybe it's a little bit of different in terms of how we think compared to what we're used to. All those things will help to set us up for success in utilizing the technology that is already coming into our schools and our clinics. So can we think of a couple of ways that AI currently exists in your daily life? I'm going to pull up some icons of applications and programs that perhaps you may resonate with and perhaps use on a daily basis. You know, maybe you use email and didn't realize that there was AI involved with that. Or Netflix helps you to get to the right shows that you love, because there are algorithms built in to kind of understand which shows you may like based on shows that you previously watched. Maybe you've experimented a little bit with large language models or with generative AI, or maybe you just feel a little confused by all these terms and kind of are not sure, you know, what is happening in our world and why is it moving so fast. When it comes to clinical care, we have to think about the many layers by which technology is integrated into the way that we deliver care, the way that we teach our students and residents. But we also need to consider how our patients are interfacing and interacting with technology, because that definitely shapes the way that we deliver care. So just recently, you know, ChatGPT Health launched, and don't know how many of those on the call have already experienced patients coming to them with questions that they asked through ChatGPT, and how do I, as a clinician, handle those things? Hopefully, with some of the things that we talk about in today's webinar, we'll be able to feel a little bit more prepared for those conversations. So wanted to say, you know, ask a question out there about technology as a clinical competency. Now, we've all had to learn how to use a stethoscope to listen to the heart and the lungs, do an abdominal exam. We all have had different tools in medicine that help us diagnose and treat patients. Ask yourself, do you consider technology one of those crucial tools that need to be learned in order to practice medicine in its maximal capacity in today's time? When the patients bring their questions into the clinic, how does that change the way that they trust us versus trust technology to get answers to their healthcare questions? Let's hear from the perspective of some of my colleagues around what they think.
As a medical educator, I fear that technology will shortchange critical thinking.
I am a family medicine residency program director. What are medical schools doing to prepare students to engage with the new technologies coming into our hospitals and clinics?
I hope that in the next few slides we can bring some clarity as to how what the terminology and means in some of these terms that have been thrown around, including artificial intelligence, machine learning, deep learning. What is the difference between these? And also, as those terms have traditionally been called AI, now we're experiencing things like generative AI. And then in the next slide here, we're also stepping into the world of agentic AI. I know this slide is a little bit small, so I'm just going to call out sort of the big categories that are there. We kind of started out with AI and machine learning, then we went into deep learning, then generative AI, which, by the way, the videos that I showed were a product of generative AI. I used a program called HeyGen to make the videos of some of the comments that I've been hearing from medical educators as well as residency program directors. We're going into the world of AI agents and agentic AI. You know, these are all things that are really changing rapidly in our landscape today. With that being said, it's really important to understand some of the ways by which these large language models function so that we know how to use them with the proper guardrails and use them to the maximal benefit for clinical care. There's a concept called retrieval augmented generation, or sometimes abbreviated as RAG. And this is a picture here that really shows, what goes into a large language model such as ChatGPT or Claude, or maybe open evidence, which we'll get into a little bit deeper in a moment here. How does it take information from a prompt, a question that's being asked, as well as the retrieved documents or the information that is put into the model to generate a response? It is really important to understand that there are these key components that go into how a large language model comes up with a response. Because if the retrieved documents are from journal articles or guidance documents that are evidence-based versus if they're coming from somebody's blog, it will influence the response that it generates. And we have to be careful of that. In the same way, if a large language model receives a prompt that is very specific and meaningful, it can generate a response that meets the need of the person who's asking the question better, or sometimes if we're able to prompt it clearly and understand how prompting works. So here's a little bit of a definition of retrieval augmented generation. We're really the input through the source as well as the prompt really influences the output. And so wanted to kind of share some of these terms with the audience here because the importance of accuracy, relevance, and reliability are high stakes when it comes to medicine. And so we want to use these tools judiciously and with the proper guardrails, understanding its capabilities as well as limitations so that we can deliver our best care to our patients. So you may have experience in the clinic yourself or colleagues or students and residents using different types of large language models. And for those of you who have not yet heard of open evidence, I'm just going to share the QR code with you because this is a great large language model for clinicians as well as medical learners to access to be able to get more reliable information. So you can take a picture of this if you would like. You can grab the QR code from your phone, just go to Photos, and then click on the link. And as long as you have an NPI number, or the students tell me they can also access this for free, it is a large language model that really takes credible sources to feed information into the large language model so that the output is something that is more evidence-based. Now, a common question is, can this also hallucinate? And the answer is yes. And I encourage you to test it out and maybe even test it out side by side, putting in the same prompt with ChatGPT just to get a better understanding of what the differences are. But I've plugged in patient cases into open evidence and put in as much detail as possible and then have checked the answers with specialist colleagues to see whether or not it matches. And it is still very important and crucial to have a human in the loop, even with a trusted large language model. So it's a great tool. Some medical educators, such as program directors or faculty of residency programs, will say that open evidence is kind of like another intern that's there, sort of adding to the discussion in maybe during medical rounds. There are different ways, but it is important that we use large language models that give us the best evidence-based information as possible. That being said, it is okay to test out your prompt in different large language models just as a learning piece, and that human in the loop, really having the human oversight is really the key part. Just as the source is important, knowing how to prompt is important, and there are whole courses dedicated to how to prompt large language models properly to be able to get the maximal output that you desire. But here are just 3 really simple frameworks that you can use when you are prompting. And this is taken by my colleagues at Stanford, who gave a wonderful pre-conference workshop at STFM. You can use the RISE, APE, CARE sort of acronyms to be able to guide your prompting. But basically, you want to prompt the large language model sort of like a scenario or a case. And you want to be specific about what your goal is, like how do you want them to answer, the large language model to answer your question, or what outcome you want. Describing that in the prompt can be very helpful in getting the output that you desire. Let's go to an example of utilizing technology in the clinical setting. That is something that feels very near and dear to many health systems and residency programs as they begin to think about adopting or have already adopted AI ambient scribing in the clinic. So just as an example, this is not an endorsement of any specific products. There are many healthcare facilities that utilize Epic as their electronic health record system and may have a connection with ambient scribing programs such as a bridge in integrating into day-to-day clinical care. And, specifically for graduate medical education, the question comes up, when should a learner be allowed to use ambient scribe? That is probably the number one question I get from residency faculty and program director in my role as the Assistant Dean of Graduate Medical Education, giving a lot of these technology and innovation talks and discussions and residency programs is like, how do I not shortchange the learning and the critical thinking of my PGY1 resident? Should we allow them to use this tool at year 2, year 3? Should we let them use it right when they start residency? Like, what can I do to be really responsible in the use of these tools and ensuring that the critical thinking as well as clinical decision-making ability of the learner is being appropriately developed? So I surveyed a couple of my colleagues around the country, and these are colleagues who some are clinical informaticists or those who are just very attuned and aligned with technology. One of them said that what they do is they implement a 6-month timeline before they turn on these ambient scribing capabilities for the residents. And here are some additional comments there from this particular program director. Another program director says that they give full access starting from day 1 of residency. And they do, I would say that a lot of program directors also, and they point this out in their comments as well, kind of think year 2 or 3 is more appropriate for the time by which learners can integrate these tools into clinical notes. So when should a learner be allowed to use ambient scribe? Let's look at the evidence and see what it teaches us. So there's a wonderful article in the New England Journal of Medicine written out of UCSF on educational strategies for clinical supervision of artificial intelligence use. And it gives some really practical steps as to how to integrate technology into the learning process for our students and residents in clinic. A couple of definitions to kind of lay the groundwork for this is there are a few concepts in the literature that really speaks to the way that we're learning how our medical learners kind of how their skills are either preserved or never developed, or perhaps it might decline because of the use of technology. But in the same way, there is also the possibility for skill sets to increase, and we will hear of terms such as upskilling or adaptive skilling. And here is a graph of some of those possibilities. And early in this research, the researchers really started off with this graph of looking at these different categories. When could the introduction of generative AI help the learners to either upskill or adaptive skill? So let's orient each other to this. First is on the y-axis is using AI effectively, and ineffective use of AI on the bottom. On the horizontal axis is less experienced all the way to more experienced. And so effective use of AI in the less experienced learner will lead to upskilling. the effective use of AI for a more experienced learner can lead to even a higher rate of learning that they term adaptive skilling. The risks are with the introduction of generative AI, the possibility of either never skilling. And so let's kind of take it back to our example with ambient scribing. It is very common for residency faculty to kind of be concerned about whether or not a learner will be able to write a note from scratch if they rely on the ambient scribing technology. So, for example, sometimes people talk about if the power goes out or if there's no internet and we had to go back to paper notes, would the learner who got used to using an ambient scribing system be able to write a SOAP note by hand? There's also the risk of misskilling, and that's something that we need to be very cautious about. Is it possible that some of these AI tools hallucinate and there's misinformation that is accumulated and built and subsequent treatment plans that are built based on that misinformation? That's a huge risk that we need to understand can happen and try to mitigate as much as possible. There's also the risk of de-skilling. And I think the illustration for this comes from a seasoned colleague who recently adopted ambient scribing, happens to be a sports medicine physician colleague who was very, very happy with the ambient scribing system, but also noticed that, the times when maybe the ambient scribing didn't capture the audio fully and they needed to go back to writing the note from scratch, that it became a skill that was although well practiced over 20 plus years of clinical care, became something that was much slower. And kind of going back to the map analogy, we can kind of think of it that way too. Like, the time when you had to rely on AAA maps or physically looking at a map instead of a GPS sitting in your car, were you able to look at a map, or were you able to get to your destination faster if you had zero map, or in the days, so basically in the days of when you had paper maps, could you get to your destination faster? Or in the days of GPS being available, could you get to your destination faster or slower? A little bit of a rhetorical question. And then let's say if we are in a sort of Waymo situation where we are sitting in a car that drives itself, would we even know how to get to our destination anymore? So this is sort of like the terms that are used in the literature and some of the things that we think about and kind of have rich discussions over when it comes to the medical education setting. So this sort of research evolved into a graph that looks a little bit more complex, like this. And this was published in the final part of the paper. And again, we'll just orient you to the graph here. This is the performance in a given practice skill for a learner. And so you'll see it goes from novice all the way up to expert. And then here on the x-axis, you'll see time over time, what has happened. So if you were a novice, and then the yellow here is when generative AI is introduced, right? And that generative AI can be something like ambient scribing. It can be something like using open evidence for clinical decision support and other technologies that are upcoming as well. So if you go from, if you were a novice in the time before generative AI is introduced, how would your skill set sort of be split? So let's just kind of follow this dot here going up the graph. As you're learning, you're a novice, you're increasing your competency into almost expert here. And at some point, they noticed that, the data showed there was a break in routine practice. And how did that sort of separation happen between adaptive practice and automatic practice? So let's just go with this line here with automatic practice. We all have, those of us who've been practicing medicine for a while, kind of understand that, that first 5 years maybe is like out of, practice when you're independent, you're kind of on a steep learning curve from novice and building expertise. You're finding that you don't have to look things up as frequently as maybe in year one, now that you're in year 5, and things feel a little bit more automatic. When generative AI is introduced, you could either stay flat here, or if you could fall into sort of de-skilling or even possibly mis-skilling. So that's the one option here. The other option here, when we find that even experts are increasing their skill levels at a higher rate, we're terming that adaptive practice. And how does that happen? Is really based on critical thinking. So this study really highlights the importance of critical thinking to be able to differentiate when you're able to be the person who's on the top of the curve or the person who stays flat. And then another breakpoint here in the sort of novice who started before generative AI was introduced. Again, the AI enhanced adaptive practice, if you're using AI tools and you know how to use them appropriately, you could really even more quickly increase your skill set. There's also the risk of not adopting and not meeting the possibility of upskilling and AI enhanced adaptive skilling more quickly. Now let's go to a circle where it is more sort of somebody who started as a novice when generative AI is already introduced. They start out here at this curve and they can either really risk mis-skilling, never skilling to mis-skilling, or they can jump to AI enhanced learning and learn more quickly and get to expert level more quickly. What is it that differentiates here? It is critical thinking. And how do we achieve critical thinking as we're teaching a generation of learners who do have these tools at their fingertips? What can we do as preceptors, as attending physicians to really promote critical thinking? That's sort of the next part of the talk and practical ways to be able to do that in the learning environment. So the foundation of critical thinking, excuse me, we're kind of wanting to visit a few key concepts around adaptive practice and what critical thinking enables clinicians to do, and what type of foundational role do we have to be able to support adaptive practice in the age of AI. So I just want to focus on this middle box here around critical thinking enables us to do X, Y, and Z. It enables us to bring any kind of assumptions to the surface and to have dialogue around it. It encourages us to have self-reflection and really checking whether or not something is actually true, or is the output that we've received something that's misinformation that we need to correct. It risk mitigation of errors, and then being able to adopt new knowledge. So how can we encourage learners to preserve critical thinking now that we know the research really shows that critical thinking is key to being able to increase skill set and increase it more rapidly? This is taken from a recent AAMC AI for Educators webinar, and highly encourage those of you who are interested to visit those series of webinars. Find that they're quite high value. For teaching, in terms of from the educator's perspective, when it comes to integrating generative AI into the way that we teach learners in the clinic, it is important for us to note some categories by which a paradigm shift may need to happen in the way that we teach. So there's a clear curricular shift just because AI can be something that our learners are using. And I just want to preface this by saying, different hospitals and different clinic settings or different learning environments have different policies around AI use especially for patient care. And if there's opportunity to really level set in the beginning, whether it be during orientation before residents officially start, or if you're in undergraduate medical education, perhaps having opportunity to send those who are entering into the clinical environment in third year clinical rotations with a set of sort of AI literacy and fluency and guardrails. So for example, it may be really clear to the seasoned physician that we wouldn't put patient information such as name and date of birth into a large language model that's public, or into a large language model at all. But that might be something that a learner needs to explicitly hear from their teachers before they know that that shouldn't happen. So there may be opportunities in our delivery of medical education, points at somebody's growth by which we would share that information, right? If it's not already clear to them, or level set at the beginning of starting residency, so they're clear on what the policies and privacy expectations are. So back to the slide, in terms of a curricular shift, it's important for us to understand that AI is really shifting the way that we learn information and have a curriculum. And it may be something that whether, sometimes our policies say that the students and residents can or cannot use it, but they still are or are not. I mean, I just want to say that that is something that is possible and that happens. And so it's better for us to just understand what reality looks like and give them the guardrails to be able to use these technologies with the maximal safety and guidance. Developing critical thinking skills, so important. And how do we facilitate that? There's a deft AI model that we're going to go through in a few slides here that really helps us to have a framework. Structure AI learning, that deft model, again, we're going to be sharing. And how do we incorporate that into our evaluations? And I think the shared learning model is something that some of us may feel more comfortable with, and some of us, it may feel a little bit newer. But in this age of generative AI that's integrated into our learning and clinical care, there is real opportunity to have great conversations and dialogue. And because this technology is something that's actually new to all of us, whether we are new to medical education or we're seasoned in medical education, it is an opportunity for us, a new technology is an opportunity for us to kind of be in the same place of learning, and in our respective roles, have dialogue about how we want to use this maximally to patients' benefit, right? And so having forums to be able to have discussions and being somewhat open-minded to sort of the technologies that are incoming, and also being humble about the fact that none of us actually know everything about these technologies and how they work, that we're all in the same boat with learning, can really create a learning environment that spurs those conversations that promote critical thinking. So just want to encourage that. So here's just another reflection from the group on educational affairs on how we might, as clinical educators, adapt our teaching in order to adapt to the AI being launched into some of our clinical settings. So this is the DEF framework, and I really like the pictures because it feels really relatable, things that we probably have experienced in the clinic. Here you see a preceptor, a patient, and let's just say resident who is on their phone looking up the answers on a large language model. And so, the preceptor clearly is seeing that the student is on their phone, or resident is on their phone, and how can the preceptor really loop in critical thinking and integrate this tool into teaching. So these subsequent slides will give us a little bit of guidance on that. So the DEFT AI framework was really developed to promote critical thinking during these interactions that happen. And so it talks about the DEFT, D standing for diagnosis, discussion, discourse, E really looking at the evidence, F feedback, self-reflection, as well as dialogue, and T, integrating these tools into our teaching. And it gives some recommendations. So we're going to break this down and cover it one by one. So this is kind of a familiar scene for us teaching in the clinic. Perhaps we're in the precepting room, as the attending physician talking to our learners and debriefing the case that just happened with the patient inside in the clinic room. How can we integrate the research that we know today And I'll just say that in the topic of technology, what we know today can also change rapidly. So we might learn something as soon as tomorrow or next week, where we need to sort of adapt and understand that, new information perhaps helps us to gain better knowledge on how to handle these situations. So this is not set in stone, and it's open for additional learning. But perhaps you can start a dialogue with the learner around, specific sort of ways to do so is like asking them what type of AI tools they use. And this learner in particular responded with, I use the free version of ChatGPT on my phone. And, questioning, like, how did you use AI in this process? Like engaging the tool, acknowledging that it's being used, and how it maybe changed the way that maybe they had a differential diagnosis in their head or not. And how did looking it up on a large language model like ChatGPT sort of change the way that they thought about management and diagnosis for this patient. We could ask the learner what kind of prompts they used in the app, and kind of helped in those conversations encourage them to use some of the frameworks. But also, I would say helping them to using this opportunity to help them understand that there are other large language models out there that may be able to source information from more evidence base. So, for example, open evidence, and encouraging them to use that instead of ChatGPT, or using both and comparing so that they know sort of they can evaluate the output and see why it's different and understand why they would use one large language model over another. Those are all things that we can use in our teaching and in integrating these tools. E stands for the evidence. It's good to just ask the question, like, how do we verify that the output was accurate? And you see here that the learner, had the response of, I didn't really verify it. The answers seem pretty reasonable. It's important for us to kind of think about questioning whether or not they think the information that was output was something that was credible. Is it accurate? Is it safe for your patients? And then we learn a little bit more about how the learner is using some of the information they're gathering through different social media posts, perhaps, and just, encouraging critical thinking, asking the questions. F standing for feedback. With sort of this open discussion and conversation, asking questions so that the learner is able to reflect on how they can grow in their opportunities to use AI, and looking for specific examples. So here in this example, they talk about interpreting EKGs and chest x-rays, or thinking about that as a future possibility. But using this opportunity to say that human in the loop, you can trust, but you must verify, or trust with a grain of salt, however you want to think about it, is something that's really important. And then lastly, teaching. As the educator, you can provide focused teaching based on sort of the findings that you learn from that interaction with the learner, and begin to talk about specific recommendations on how to improve the way that they use the tool, what they think about the source, the output, what large language model, is preferred in a clinical setting, and how to watch for errors, how to mitigate the risks, how to avoid misinformation by really asking these type of questions. So in this paper, they also talk about AI engagement and this concept of a centaur versus a cyborg. And there's a graph that's going to illustrate this a little bit better. But in addition to, encouraging the questions that spur critical thinking, it is also recommended to kind of think about what we're getting out of these large language models. Are they situations by which it's a low stake environment, or is it a high stake environment? right? That kind of dictates, would we kind of integrate the cyborg or the centaur? So let's kind of just break this down a little bit. So using examples is always helpful for me in terms of understanding like what these graphs mean and what they say. So there are a couple examples here where let's just say you are in a low stakes environment and you can collaborate with a large language model with very little evaluation. And those low stakes environments, like if you don't have to spend a whole lot of time checking because it's not something that's going to really influence, whether a medical decision is determined one way or another for a patient. So, for example, drafting an email and using AI for that is something that we can use pretty automatically without being too concerned about how high stakes it is, right? So it can really save us time. Maybe some of us have sort of AI capabilities in drafting messages with our patients. That may be a little bit more high stakes than using it to talk with your best friend. Some, and actually many students will use generative AI to build study plans. That's usually pretty harmless in terms of it's just a matter of, my board exam date is in 2 months. Please generate a study plan based on the test scores that I've gotten out of my practice exams. That is something that is, in the big scheme of things, pretty low stakes. The mistake might be, 2 days on cardiology and 5 days on respiratory when it should have been the other way around. We can live with that, right? Another situation is using a validated AI-based ECG reader, and that is something that is a little bit more high stakes. It's patient related, but it's validated, right? So we can probably, for the most part, trust it with less worry about what the risks are. Let's look at this corner here is using an AI ambient scribe with a patient to listen and draft a progress note. Drafting that progress note, probably pretty low stakes. But when does it become a high stakes situation is when it comes to clinical decision support. So let's just say in the subjective part of the note, right? It's just capturing that information from the patient. The ambient scribe is doing that. And then, but when it comes to the assessment and plan, we really want to pay a lot of attention to it as to whether or not it's accurate in the delivery of sort of transcribing that patient encounter and making some clinical decisions around it. So this just kind of serves as a model for a bit of a paradigm shift when it comes to integrating AI tools into the way that we teach our students and residents. So just a little picture here to kind of, say our traditional ways of thinking about how to teach this may require a little bit of adaptation or integration in ways that that we never thought about before, but perhaps is something that is well worth adjusting for practicing medicine and teaching learners when they're using these tools. So this is just a graph kind of looking at teaching while we're learning and how technology plays into it. So having sort of being an educator and supervising with technology in the picture is sort of something that is a little bit new to us. And it's okay to remember that as teachers, we're also learners. And so we're learning side by side in this new terrain, and having that dialogue and navigating this together with our learners is something that is positive and that spurs critical thinking for our learners, but also for ourselves. It can feel a little bit uncomfortable, like the picture with the car driving on icy road. It's like, okay, I'm used to driving on a regular road where if I press on the brakes, it usually stops the car. But if I'm driving on an icy road, I have to remember to leave a little bit more distance for safety between me and the car in front of me. Slamming on the brakes is actually going to do something very different to the car than sort of letting off gently in an icy terrain. And so there's that uncertainty and that discomfort that we all feel, and it's okay to feel that. Just it's an opportunity to like guardrails in place so that we can kind of come into the situation with as much support, as much safety in place. So whether that be thinking through how your institution wants to implement policy, is it the first day of residency that you get to use ambient scribing? Is it the second year? Those are conversations that are well worth having among the educators and faculty. It's really encouraged to have reflective practices to be able to promote critical thinking, like asking why is so much more important because we could either just take in the information that's given to us, and if it's misinformation, it may be leading us down the wrong path, especially, and that can be high stakes in a clinical environment. It could be high stakes in other non-clinical environments as well. But when it comes to our patients, I think we all have a special place of wanting to ensure accuracy and that we're delivering the best care possible. Having that shared learning model and engaging together is something that we can have as part of our conversations, as part of our teaching. Maybe the student has a new large language model that you've never heard of, and it's an opportunity to learn and engage in why they're choosing to use that over another, or they have a new tool for making videos. It looks really cool. You wanted to make one too, for whatever purpose. It's okay to learn from one another. In this environment, there's kind of like a strange thing that happens, and sometimes we may find ourselves in an inversion of expertise. So sometimes our learner will know more than us. Now, learners probably will not have the same level of clinical expertise, right, that somebody who's teaching and been practicing for 20 or 30 years has. And so that is always important to recognize that you do have that knowledge. But sometimes when it comes to technology, like I'm asking other people to show me how to do stuff on my phone all the time, it's a shared learning process. All right, so here are some of the key takeaways, and I just want to take a quick peek at the chat because we're nearing the end here. We will have a little bit of time to address these. Just wanted to also share a resource from the Society of Teachers of Family Medicine. They have like a free, even if you're not an STFM member, artificial intelligence and machine learning for primary care curriculum. So those of you who are in primary care and want to have maybe take your residents through a specific curriculum or want to build some foundational knowledge, this is a great resource put on by several of my colleagues where I serve on AI medical education task force with. And this material is also being updated. That's one of the things that we're doing. And so check back frequently. But I found it to be fascinating and a nice resource to kind of feel like it's really relevant for clinical care and for medical educators in particular. So with that, welcome questions. So I'm going to just take a look in the chat here, and Nikki and Alenta, if you want to help guide, as you've probably been looking at the chat here, we can address the questions. So unfortunately, there is not CME for today's session, but if this is something that is of interest to folks and we want to do a little bit of series, we can consider CME for the future. Let's see. Okay, a little bit of more housekeeping items. And thank you for some of the nice feedback here. Okay, what opportunities are there to visualize the essence of what causes diagnostic findings to be seen? So having a depiction of cardiac anatomy and physiology that may cause ischemic pattern EKG. Okay, this is a long question. Let's see. Important to maintain the connection with the patient person. I'm not sure I fully understand this question, so I'm going to skip it and maybe Alenta or Nikki can help me. Let's try to go back to the last QR code. So there is a QR code for the STFM resource. And then there was also, this was earlier. Okay, so that probably was for this one at 1:48 Pacific time. Okay, can you please put back the last slide? Okay, so the QR codes are here. And then there was the other QR code was for open evidence. And you can also just type that into a search bar and grab it as well. So open evidence is the large language model that's recommended for clinical use. All right, just looking at the chat here. Thank you for your comments and your participation today. I'm going to try to see the question about visualizing the essence of what causes diagnostic findings to be seen. It might have been something that was a response as I was talking. If the person who asked that question wants to ask it again in the chat, if it was not addressed, happy to try to answer that question. And then I think there may be a question and answer here by Dr. Pecchia. Hi, Greg. Might we be able to share the recorded version of this? Okay. Okay, I do have an answer to that. My understanding, and please correct me if I could be more accurate here, is that, okay, Nikki is going to speak to this. I think it's going to be posted on YouTube is the short answer. So Alenta or Nikki?
Correct. We will post it on YouTube and share it with everybody that's registered for this webinar as well, the recording and the PowerPoint slides.
Okay, thank you. How do we prepare residents to respond to patients who use AI to self-diagnose before coming to the office if the patient has the same plan as the provider? Will they stop coming to the office unless they need a prescription? Well, that's a very nice question there. I will also say that in Denver, they've allowed for AI to prescribe medication. So that just as a side comment, and I'll try to answer the bulk of your question here. I think this notion of patients going to large language models for medical advice is going to be something that we see more and more. And I think that, to be just really honest, unless we engage in these technologies and find that, and our patients are finding, how do I word this? I think if our patients see that we're up to date with the technology that they're using, it's going to help to continue the trust that they have in us. If they're finding that the technologies are serving them better, whether it be through access or cost, I think we are going to have to work much harder at making sure our patients see the value of a human-to-human encounter. And I guess this is where I'll speak on my passions with respect to osteopathic medicine and the philosophy that we have. I think as osteopathic physicians, and our MD friends also are very good at doing this, but I think we have a unique ability to really focus on sort of high touch delivery of clinical care. That is something that is very much advantageous as our world becomes increasingly automated with these technologies coming into the clinic and coming into our learning spaces. That sort of highlight of what we bring in the osteopathic philosophy, being very human-centered, being very relationship-centered, is something that I think will never be replaced, and something that we will naturally lean into, because so much of the information and the transactional aspects of medicine are going to be automated. And so with that, patients probably are still going to want that human connection and come to us to find that, I mean, I think that there are a lot of possibilities in the future around what technology can do. But for today, I don't think technology can do a pap smear or a knee injection. And so we're not being replaced anytime soon. But if we don't adapt the way that we practice medicine and teach our learners to use these technologies in a way that maximizes their practice of medicine, the patients will see through to that, and I think it'll compromise the trust. So that's how I'll answer that question. Looking for more questions here and also in the chat. Oh, I think this question here about discussing the potential risks of not adopting AI. Oh, this is interesting. I think I spoke a little bit on the risks of not adopting AI from the perspective of our patients engaging a lot in it. But there's a whole nother sort of set of questions around litigation, and whether or not we would be in a place of risk if we are or are not using AI. I think that is the question that I'm seeing in the chat here. So, for example, the studies have really shown that for detecting breast lesions, AI can be more accurate and diagnose those breast lesions faster. And so the example that was shared is a radiology image processing and missing something because we haven't adopted it. So that is a wonderful consideration to think about. And one thing that I'm learning is from how AI is different from the perspective of a primary care clinician versus one that is versus a field that is a little bit more concentrated on diagnostics and even proceduralists. We're looking at this from slightly different lenses, and it is important to have the awareness that there are risks to also not adopting in certain areas by which we practice medicine. So radiology is a great example for that. When it comes to litigation, some of the common questions are, if the AI, say ambient scribe, really misinterprets something, and that goes into my clinical note, just want to remind us that human in the loop is essential, and that at the end of the day, when we sign off on the note as clinicians, it is our note. And so that is something that we need to share with our learners so that they understand, the accuracy of the note is something that they take ownership of, not the AI. I hope that helps with the questions. All right, just scrolling through here. And if you're seeing something, Alenta and Nikki, that I'm not seeing, feel free to call it out as well.
Not seeing anything new.
Okay. Well, just want to say thank you to everybody for your time and your participation in today's webinar. It's really a pleasure to speak to you on this topic, and we hope that we can bring resources that really help with your day-to-day and as teachers, as educators, as well as learners and clinicians. So thank you again for joining us today. We're really grateful that you took the time. I want to hear more about what PDs want first from students. So for those who have to go, feel free. There's still a little bit of time on this webinar. And there was a question around what program directors want from students. If you are a program director and you want to share that in the chat, please, I don't know if there's capability for you to share, but really welcome your perspective on this as well. I'd be happy to share what I've heard from different program directors, giving some of these talks up and down the state of California. So program directors, I think they're first more focused probably on the residents because of some of the unknowns with AI, and what the residents are doing are a little bit more involved in clinical decision making, which is a little bit of a higher risk. So they tend to focus on residents and when it's appropriate to integrate. I think with students, it seems to have a little bit of a different flavor in that the students are sometimes bringing these tools into the clinical rotations. And in some cases, I've heard like faculty and program directors who may be a little bit newer to these technologies kind of start asking students questions on how to use some of this. Sometimes the students are using them perhaps in ways where on the front end in undergraduate medical education, we can do a better job of teaching them some of the guardrails. So sometimes program directors will say that they're seeing students use ChatGPT and it's not really appropriate. That is something that I've also heard. And I'm trying to get to, oh, okay. So thank you, Marla, for clarifying, because I don't know if I'm getting to the crux of your question. I guess I'm thinking in terms of who they might pick as residents. Oh, okay. This is it. Oh, thank you so much for clarifying, because I do have a good answer to this. So one of our colleagues at one of our comms has a digital health curriculum. And the stories that I've heard from that is the residents, I'm sorry, the students are matching into, with some of these competencies built in the undergraduate level, are matching more into their residencies of choice as a result. So I'll give you an example is one of the students last year really wanted to match into diagnostic radiology. And because on their audition rotation, they were able to speak to some of the aspects of digital health that they learned in their digital health track at their medical school, it made them look really impressive and they got into their dream residency program. So that was super cool. Also spoke with a student, now fellow, but former student at that same school who had the privilege of being a part of the digital health tract, the first ever for osteopathic medical school. And then went on to become a clinical informaticist and is now a clinical informatics fellow at Stanford. And so I think this does, having the literacy, having the knowledge, really puts students in a good light as they go out into clinical rotations. Okay, I think I got to that question. Thank you for asking it. It's a great question. Okay, well, we're at time. And so thank you again, everybody, for joining us. And we wish you a wonderful day. Take care.